Well, hello, everybody. Welcome to iCubed, episode 28. This is Dr. Alice Lee. It's June right now as you're watching this episode, so I'm hoping that all of you are enjoying a nice, sunny, easygoing summer. Here in Arizona, it's still kind of just getting out of the winter crush in April. I have a brand new guest I'm so excited about. This is my dear friend, Dr. Tiffany. I worked with him about 10 years ago, and I'm so excited to have him join us. Please introduce yourself.
Thanks, Alice. All right, well, I'm Brian Tiffany. Yeah. I went to medical school at Washington University in St. Louis. Wonderful. And did my residency program in Detroit Receiving.
You did?
Stayed there for a couple years after I graduated as an attending. Did a research fellowship there, and then I have landed in Phoenix. Been here for about 20 years, working in the east side of Phoenix, First Maricopa Integrated Health Systems, where you and you were a graduate of there.
That's right, Maricopa Medical Center, exactly. Yes. And I'm very proud and always never miss a chance to mention it.
Yes, so I was faculty there for a few years, and then chairman for a couple of years, and then moved out here to the East Valley and have been at Chandler Regional and Mercy Gilbert ever since.
Well, you have gained a new hat. What is your new hat?
I have. I've gone to the dark side. Hence the Darth Vader here on my desktop. But I'm a chief medical officer for Dignity Health at Arizona General Hospital System.
Yeah.
So it's a hospital system of two hospitals, which are full service, and then we have a network of 12 freestanding emergency departments that feed into the two hospitals and into the rest of the Dignity Health system here in the Valley.
Well, let's just jump into this case. Let me set up the scenario. So I don't know how it is here at your hospital, but in my ER, Banner Baywood, the techs get the EKGs when the patients come in to triage, and they have to find a doc, to take a look at it, to not miss the STEMIs within about probably the 10 minutes or so window, right?
Yep.
And so this is the last hour of my shift. It never fails. Difficult cases come in at that point. So I have a tech bring me this EKG.
Oh, yay. This is what you want at the end of your shift.
So, what do you think, doctor?
Well, it certainly looks like they have ST elevation in their inferior leads and some maybe reciprocal changes. That's not quite right. AVL is down, but the lateral leads in V5 and V6 are not. I would still label this a STEMI. I think this would I would be immediately getting our cardiologist involved.
Very good.
Have the conversation about the cath.
So, yes, bring the patient back. This looks like a STEMI, right? So get me the old EKG in the meantime. It takes a few minutes to get the patient back here, right? So I'm looking at the old EKG, and here it is.
Okay.
What do you think?
Oh, look at that. They're side by side. Oh, yeah, okay. He's got a little lateral stuff happening.
Yeah.
So, okay.
So within a few minutes.
Well, the other point to make is if you look in his V2, he's got a pretty good R wave there, and with some ST depression maybe in V2, so you start thinking about a posterior extension here. So I want to see right-sided.
Oh, totally, yeah. So for me, when I looked at the old one, it really convinced me. This is a STEMI. So then, you go into the room and you find out he's a 64-year-old guy. He's got diabetes, hypertension, coronary artery disease. He says he's had 7 stents before.
Okay.
7 stents before, right? And now he's having severe pain. That's why he came in. He tells you he just had cath yesterday. And he was told by the cardiologist that 3 out of his 7 stents are actually occluded. And they didn't stent him. They were going to bring him back for a coronary atherectomy.
Okay.
All right. So then, it was just discharged today at 1 o'clock. It's about 10 o'clock at night now. All right. He goes, I woke up with severe chest pain and nausea just 30 minutes before.
Okay. All right. This is too easy. I think I'm missing something.
All right. So physical exam. He's a typical, 60-something-year-old guy. He's got a little bit of clamminess when you touch his skin. Just a little. He's uncomfortable. Okay. Vitals, blood pressure is 147 over 98. His pulse is 68, respiration is 16, his sats are 94. So really, really quite normal vitals, essentially. Temp is 37. Okay. So what now?
Okay. Well, your initial ED management, right? So you make sure that he has or has gotten aspirin. And this is a patient that I would go ahead and heparinize. I would at least give him a bolus.
Right.
Because our cardiologists typically they're happy to go with a bolus. I wouldn't even call and ask if that would.
Right, exactly.
And obviously you're going to get that guy straight to the cath lab, to the cardiology and call the cath lab.
Right. Yeah.
And he's hemodynamically, he looks stable.
He looks great,
He looks inferior. There's no evidence of a block or any bradycardia, nothing I'm worried about there. And maybe may give him a little volume to be extra safe with him, because he's inferior.
That's right. So those are very similar thoughts to what I had at the time, going, this is a STEMI, it's inferior, maybe right-sided. I'm going to put him on nitro, call the cardiologist. So I call the overhead STEMI alert. I don't know how you guys do it at Dignity. So the house supervisor comes to the emergency room. I tell her what's going on. And then she calls the cardiologist, right? So it takes some time to do that. In the meantime, I look up some more records. So this gentleman's cardiac cath from just 1 day ago says multivessel coronary artery disease with high-grade restenosis of the mid-circumflex, as well as the proximal and distal mid-right coronary, right? And so the cardiologist's recommendation on the cath report was that the patient's medical therapies will be optimized. He was to be brought back and scheduled for elective laser therapy for the restenosis of his coronary stents, just like the patient was told. So the interventional cardiologist calls pretty quickly, calls back.
Okay.
I describe the EKG very well.
Yes. And
first thing the cardiologist says, I'm not taking this patient to the cath lab. He was just cath yesterday. There's nothing we can do for him. What? It really flabbergasted me.
Yeah.
It totally flabbergasted me. So what now?
Well, all right. I'm going to keep wearing my ED hat, not my CMO hat.
That's right.
So, I would try to have a collegial conversation with him.
Sure.
I mean, he's the subject matter expert.
Yes.
Right. I am a subject matter junior expert in this. So
that's a good way of saying
I
that.
think of it, and would interact with him like that. But I'd want to know, okay. I mean, he's got ST elevation, which is new.
Yes.
And what do we need to do? Do we need to do something out of this? Is there a technical reason? Maybe you can't get a wire across. You can't do an acute. I don't know what the laser atherectomy looks like. Is that something you can do acutely?
Right.
But I got a guy that's having a STEMI in front of me, and I have to address that. So if you want me to medically manage it, I will. I would do that. But I just want to make sure we're on the same page that he's really having a STEMI.
That's so totally exactly the way I went about it. I was had to use my. I don't agree with you strongly, but I'm going to remain professional voice.
Yes.
Because this was completely unexpected. When I talked to the cardiologist and was told that the patient was not going to go to cath lab, it shocked me. So, the cardiologist hadn't even looked at the EKG, but I described it. This cardiologist I've known for more than 10 years. Okay. Yeah. So I described it, and again, we had this long discussion, and then I made sure that the cardiologist did not finalize the decision until the EKG was reviewed by this cardiologist, right? So I had the house supervisor make sure that she texted the EKGs, both of them, the old one and the new one, to the cardiologist on call. Well, I'm finishing up. I put the patient on nitro, and I put the heparin on the patient, heparin order for the patient. And then next thing I know, actually, the house soup says, "Oh, the cardiologist is coming in for the cath lab," and
he changed his mind.
Yeah. So I'm like, phew. I admitted the patient to the cardiologist, to the hospitalist. Patient goes off to the cath lab. End of my shift. I am so happy to be gone. I'm out. Right. But the rest of the story.
Dun, dun.
Dun, dun, dun. So the next day, I find out something about this patient, and I had my dear colleague Duke Keller record what happened.
So Dr. Lee kind of wrapped him up, and the patient was on the way to the cath lab, and she left for the night. And then 10 minutes after she walked out the door, they called the code blue, and that's when I showed up. By the time I got to the room, the patient apparently was in VTAC or VFib, but pulseless and unresponsive. And so they defibrillated him, and And he woke up immediately and was like, "What's going on?" Perfectly awake, talking. And then a minute later, same thing. Went back into this VFib. We defibrillated him again. And then he woke up again. And this happened 3 or 4 times. Eventually, I got amio in him, started a drip, and he stabilized, was completely with it, alert and oriented, didn't need an airway, and we got him to the cath lab. And I believe the cardiologist put in a balloon pump, and ultimately the guy survived and did well.
It was literally, if you look at the timeline, it was literally like 12 minutes after. Yeah. So this is...
I feel like I remember getting turnovers like this. I'm kidding.
So
yep.
The guy went into VTAC arrest 3 times in the ER before going to the cath lab. And then he went into VFib twice while being cath.
Yes.
The emergency cath report showed the RCA was 100% occluded at the proximal, and it was in the stent. There are multiple stents that are seen without contrast running through. We did get TIMI 3 flow, and the patient's ST has resolved, and he felt better. A 2.5 by 12 millimeter emerged balloon was able to be passed, and I passed a Onyx drug-eluting stent. And then this is the post-stenting EKG that same night of the patient's. This is
back to baseline.
Yeah. So you remember what the first EKG looked like, right?
Yeah.
And so now this is the post-cath one.
Yeah.
And he was pain-free at that point. So that's the clinical scenario, actually. A little different than what you might have expected, perhaps, Brian.
No, that's good. No, I like it. I knew you weren't going to just pitch me a softball.
Exactly. So, Brian, my screencast, iCubed, every one of the episodes, I try to present a case, and then the latter half of the screencast, I'd like to focus us into 2 different learning points, just so we're not too scattered, and it also helps for us to retain the main points for the screencast, right? So my first learning focus, have you heard of this, the 5 C's of consultation in ED?
I'm not sure I know the 5 C's of consultation.
Well, you shouldn't have heard, and I shouldn't have heard, because the initial study or article that was published about the 5 C's of consultation in ED was 2012. Okay. So, for us emergency physicians, we consult doctors or medical staff all the time, right? Probably, 30 to 50% of the time we're consulting somebody that's outside of our specialty, right? We are always kind of encouraged to do that sort of professionally and all that, but there's been no formal sort of method to teach residents or teach attendings even to how to perform the consultations well. So this study back in 2012 was Dr. Kessler et al. In the Journal of Emergency Medicine. And the study was a qualitative analysis of emergency medicine consultations in order to formulate a framework for physician-to-physician communication. Because there was such a dearth of literature about this, sort of a soft skill, if you will. So this article or this study was a very small study, but the method was, number one, there was 3 parts to it. One was there was an informal interview in the emergency department, and then there was a 10-question survey to the same participants, physician participants. Then there was a semi-structured 1-hour group interview. The results of this study, there were 29 emergency medicine physicians as well as specialists that completed the study, and 3 themes were identified that would be very helpful or crucial to successful ED consultations, right? So it was organizational skills, interpersonal skills, and the medical knowledge of the consulting physician.
Okay.
And the conclusion of this study was that they introduced the 5 C's of consultation model. The 5 C's consultation model is contact, communication, core question, collaboration, and close the loop. So I'm going to play a segment of the EMRA teaching video because it will explain it better than I.
The 5 C's was developed to optimize consultation by structuring communication. There are 5 steps.
Yes, and the first C is contact. Each party should state their name, their service, and role on the team.
The next C is communicate. Verify the patient's name, location, and medical record number. State the diagnosis that's been confirmed or that you suspect. Provide them with a brief synopsis of the history, physical exam, and any ancillary data that you might have. Share any interventions you've made and any response to those interventions.
The next C is core question. Be clear up front why you are calling the consult. Are you calling for an admission, for surgical intervention, for a procedure, or further recommendations on management? The core question is typically a one-line statement. And an important part of the conversation is also time expectations. Do you need the consultant right away? Are they going to be there in 20 minutes? Or some other mutually agreed upon time?
Next is collaborate. Ask the consultant what questions they have. Ask if they need any additional studies or therapies prior to evaluation. For procedures, you can ask if they need any supplies to be at the bedside.
And the last C is close the loop. Review any actions that you're going to take prior to the consultant's evaluation, and review the actions that the consultant is going to take. And thank the consultant for his or her time.
Right. So that actually explains it pretty well. And I think that old practitioners, as you and I are, it just kind of comes naturally nowadays. I mean, we might have learned it along the way, but it's good to have it sort of structured and then be able to have a way to teach this soft skill. Learning focus number 2, the difficult consultant. So, who of us have not had to deal with a difficult consultant?
All of us.
I'm going to probably engage you in putting on your CMO hat here shortly. But so in the same study that Dr. Kessler published, they talk about a few strategies, if you will, to deal with the difficult consultant. So these are just a summary of them. He talks about make concessions sometimes, right? Mm-hmm. And sometimes you have to be willing to compromise with the consultant. You have to negotiate. You might have to climb the seniority ladder, going up the administration ladder. Some of the more sort of polite things, I guess, when you're dealing with a difficult consultant would be to avoid criticizing or questioning the consultant in front of a patient. Always maintain professional standards despite what the other party has said or done. And offer the patient an alternate consultant if there's major disagreement regarding the treatment or the disposition. So I'm going to just play.
But there are other consultations where there may be a difference of opinion between providers. And based on the nature of the issue, the potential for disagreement is predictable.
Yeah, when this type of situation arises, thinking about how to collaborate with the consultant could be particularly important. Here's a scenario in which a senior resident is taking care of a patient with congestive heart failure, who is well known to both the emergency physician and the cardiologist. However, there's kind of some uncertainty whether the patient truly requires admission. Let's take a look.
Hey, thanks for calling. This is one of the ED residents calling about an admission.
Okay, what's the story?
Well, Mr. Jones is back. He's in a heart failure exacerbation. I think he needs to be admitted.
Again? I just saw him in clinic last week and he was doing fine. Has he been taking his medications?
His meds? Yeah, I think so. I can ask him. But he came in, he was short of breath. He was pretty hypoxic. I think he was... Give me 1 second. Yeah, it looks like he was about 92%. I think he really needs to be admitted.
You know, every time we admit him, we just give him a few doses of IV Lasix and we discharge him. You guys could do that in the ED and then have him follow up with us next week. His labs look okay, right?
Yeah, his labs look fine. I think that'll be okay with me. I'm happy to treat him. But, I'm not sure where he's going to shake out over the next 24 hours, so I'd feel a little more comfortable if he was admitted.
Well, just have him call my office tomorrow for a close follow-up soon. I don't see a need to admit this guy right now. Let me know if you have any problems.
What do you think?
Oh, yeah. It was a terrible presentation. It was begging that cardiologist to get upset with it.
That's right. Yeah. So
yes. He didn't have a focus on what he wanted, and I see this in our younger physicians or our mid-level providers or advanced practice practitioners who will fall into this trap sometimes. And just like, this guy, he just looks like I need to give him admitted, I think, with no clear expectation of why.
Right.
The classic clicking, like, let me go back and look at the EMR and dig through it while I'm talking to you on the phone. Those are all things that especially in the middle of the night, will set off a consultant. So you need to be prepared and be respectful and collegial when you're calling these guys.
Right. So here's another clip.
Hey, thanks for calling. I'm down in the emergency department. I'm one of the second-year ED residents. And I'm calling because Mr. Jones, one of your frequent heart failure patients, is here in decompensated heart failure, and I think he needs admission.
Okay, yeah, Mr. Jones. His MRN's 5432130.
I know this guy. He's here all the time.
I just saw him in clinic last week. Why is he back today?
Yeah, I know you know him well, and I've taken care of him before, too, and I know he frequently comes to the emergency department in heart failure. But today I'm just a little bit concerned because he looks a little worse. He came in, he was in moderate distress. He was hypoxemic to 90, 92%. He was also hypertensive to 190 over 100. He had bibasilar crackles on exam. His chest x-ray did show pulmonary edema. We checked his troponin and an EKG, and that was those were normal. But he hasn't really gotten all the way back to baseline with some nitro and some Lasix that we've given him.
Yeah, he comes in all the time for this. Usually he misses a couple doses of his medications, his blood pressure skyrockets, and he gets flash pulmonary edema. Once you get his blood pressure down, restart his home medications, he's going to be fine. It'd be nice to not admit him and get him home.
Yeah, I completely hear where you're coming from, but today I feel like it's a little bit different than in the past. He's gained 5 pounds. He has been taking his medications. I've even asked his wife. He has some worsened pedal edema. And I really think that he could benefit from an admission. I think maybe a little observation, some diuresis, and maybe even a repeat echo could do him a lot of good. Would you mind evaluating him at the bedside with me?
Okay, that sounds reasonable.
Is he on a nitro drip, and have you given him Lasix?
Yeah, he was on a nitro drip. We're titrating him down on that currently. We give him 40 of Lasix, and he's put out 200 cc's of urine.
Continue weaning the nitro drip and give him another 40 of Lasix. Sometimes it actually takes a high dose, like 80 milligrams, to get a good diuretic response. Let me finish this other admission, and then I'll be down.
15, 20 minutes sound good to you?
Sure, I'll see you then.
Yeah, that sounds great. We'll continue to down titrate the nitro. We will give him another 40 of Lasix, and we'll see you down here in 20 minutes. Thank you so much.
Well, that was a nice display of partnership. The consultation was much more effective.
It really was, and it helped that the emergency physician knew the details of his patient, was able to outline specific causes of concern, spoke the language of the consultant, and was also able to articulate what would be accomplished through hospitalization.
Everyone stayed professional and listened to each other.
There was also good closed-loop communication in confirming the next steps.
And seeing patients together at the bedside offers many advantages. It brings more personable, face-to-face interaction. It enables both parties to confirm the history and exam and the recommendations as far as the patient being the most important person in this.
Absolutely.
So even though this is a teaching video for residents, I think it's so useful.
I think an important point is knowing what you want when you call.
Yeah.
And have, it's you're laying out the argument for what you want.
That's right.
Clearly.
That's right.
There's going to be times that you're actually calling for advice.
Right.
And you should make that clear up front. I don't know what to do with this. Here's what I think.
Right.
And here's what I'm seeing. And I need your expertise. And you make them feel like the expert. Because that's what they are. That's why you're calling them. But a case like this where you just call them and say, I think this guy just needs to be admitted. Right. You don't have data ready to go. You don't have a clear reason why you want him in. Right. It leads to trouble. So the second one was obviously much better. That was a great interaction.
Right. So
and the other piece I think is important is they made the point about speaking the consultant's language, which ought to somehow be another C, making sure that's clearly there. Because the classics are things like ortho, or ophthalmology has been a hot topic because you have people, I think, that literally will call the ophthalmologist and say, this guy isn't seeing very well. I need you to take a look at him, right?
And what does that mean?
Yeah. And they say, what's a visual acuity?
Right,
you know, like, oh, maybe you have that.
Right.
Then they want interocular pressure.
Right.
So did you do a slit lamp? Well, no.
Right.
I mean,
Right. That's
yes.
so frustrating for the consultant.
Yes.
Because they're actually trying to make a decision over the phone.
Yes.
But they need the data.
Right.
You're trying to get someone to describe to you what you would want to see in a patient if you were to examine the patient. So it is. I can see how it can be very frustrating for the consultant when they can't gather that, and you're just kind of wasting their time.
Right. Listening to you present like a medical student.
Yeah, when we're attending. So when I was researching this and learned about this 5 C's, I was thinking, okay, let me see if I can apply this to my my patient case. So C number 1 is contact. So I contacted my consultant. I introduced myself. The cardiologist knows me. So, hey, it's Alice Lee. C number 2 is communicate. So in my patient's case, I tell the cardiologist, I have a 64-year-old man with a STEMI on his EKG, and I describe the EKG to the cardiologist, right?
Right.
So C number 3 is the core question, which is what I want out of the cardiologist, I guess. I've called a STEMI alert, and I just want to know how long you're going to be before you come to a cath lab, or did you want me to call the cath lab for you? I get this answer. I'm not taking the patient to the cath lab. Ta-da! Stops me at C number 3. Okay. C number 4, collaborate. We have a lengthy discussion on the phone. And we collaborated, which is that the cardiologist agreed to review the EKGs. Right? All right. C number 5, which is closing the loop. And I told the cardiologist, I'm going to ask the house supervisor to text you the EKG, and then you can make the decision at that point. So that's an expectation I was setting up, I guess, at the end of this somewhat shocking interview consultation. So those 5 C's, I thought I applied pretty well in this situation. I am so honored and pleased, Dr. Tiffany, that you joined me today.
Absolutely, Alice. Thank you so much for having me. It's great to meet up with you again and catch up a little bit.
That's right.
I've enjoyed watching this over time as you've been doing it. And it's been honored to be a guest on.
So thanks everybody for watching this month. I hope you enjoyed it, and I hope you learned something this month as well. We'll see you next month. And don't forget, if you see me at a conference, come and say hi. I don't bite. I promise. See ya.
Bye, everybody.
Bye.